Perfect, perfect. So, hello everyone. Sorry I wasn't able to be there in person this year, but thank you very much again for the invitation, and Dr. Yakov and the rest of the committee for organizing this great conference every year. I would like to talk to you about the use of artificial intelligence and simulations for TAVR optimization. These are my disclosures. So with expanding indications for TAVI, we also face increasingly complex anatomies. There's a lot of variability from patient to patient in terms of the anatomy, the leaflet or annular calcification, the coronary heights, the access options. That's why now the need for a personalized, precision-driven approach is very important. And also the TAVI expanding in younger populations, the lifetime management becomes key. There are several risks, as we know, associated with TAVI, including coronary obstruction, annular injury or rupture, conduction disturbances, paravalvular leak. So it's very important to have a very accurate pre-procedural planning to minimize the risk for these complications. Obviously, the CT angiography, the gated CTA, is a cornerstone for pre-TAVI evaluation in order to choose the right valve and the right size. However, as we all know, this approach has the disadvantage that it's a static approach. It gives us some static images, and sometimes it lacks the dynamic 3D perspective. So here comes AI and simulation softwares that provide an extra dimension, an extra layer of understanding of the anatomy. Here now in the United States, we have been using the DASI simulation software that uses data from the patient CT scan to reconstruct the 3D model, and then you can simulate all types of valves and check for all different kinds of complications. And you can see how a typical case would look with a balloon expandable valve. So there have also been developed AI algorithms for automated measurements of CT scan. This was a study published at the journal of Sky last year, showing two of the algorithms that actually showed that the accuracy of the measurements, there was significant agreement between this AI algorithm and the expert measurements. And this is also another area where AI is being developed. So I'll present a few cases that we have used this software and we found it very helpful. So first of all, as we know, bicuspid aortic stenosis is a challenging anatomy for TAVI. Here we had an 85-year-old female with severe bicuspid AS. And you can see there's a raphe there, probably type 1 severs. And as we know, the bicuspid, there's the anatomy of the root is asymmetric. The non-coronary sinus in this case is much larger and deeper than the left and the right coronary sinuses, and most of the times in this case we would like to deploy high. So we can use the embedded geometry feature of the CT software. However, again, this is a static feature. So here we simulated with the DAS simulation software the 23 millimeter S3 valve at a conventional depth, like 80-20. And then we simulated a high deployment, just a couple millimeters, 2-3 millimeters above the true annulus and the non-coronary sinus. So with this software, we can estimate the coronary obstruction risk. Obviously, in this case, you can see how the leaflet and the valve are really far from the left coronary. There's this index that takes into account the distance from the coronary artery, and then the diameter of the coronary artery. And this ratio can predict the risk for coronary obstruction. If it's less than 0.7, there's high high likelihood for coronary obstruction. In this case, it was 3.1. Obviously, the coronaries look clear. We can also estimate the risk for paravalvular leak. We can visualize gaps from the aortic and ventricular views. The rule is if a gap is less than 1.5 millimeters, usually you don't have significant paravalvular leak. And here we also simulated a self-expanding valve, the Evolut in this case. And due to the elliptical shape of the annulus and the aortic root in this case of bicuspid valve, we could see a gap of 1.8 millimeters here in the aortic view, as you can appreciate also. So we ended up implanting the 23 millimeter S3, and you can see in two views, this areocaudal view, more like a cusp overlap view, how the actual result matches the simulation. And this is the aleocranial view. You can see the coronaries filling really well here with contrast, and you can see how similar it looks. So then I'll go to another case of severe AS of 81-year-old female with an STS score of 4%, no significant comorbidities, small annulus, small sinuses, severely calcified and bulky leaflets, as you can see here. And the coronary measurements were not favorable. The coronary height was 12, but the bulkiness of the leaflet and the degree of calcification was very concerning. So in this case, we simulated 23 millimeter S3 underfilled -2 mLs in order to match the annular size and not oversize too much. And you can see that although the left coronary seems to be okay, here the ratio of the right coronary was 0.46, less than 0.7, and you can appreciate that the right coronary artery is almost obstructed, and this was a right dominant circulation. So we sent this patient for surgery, for surgical aortic valve replacement, and these are some of the intraoperative images, and you can see how bulky and calcified the leaflets are, and this was actually the reconstruction from the software. The patient did very well with surgical aortic valve replacement. So this software can also help us with cases that we need to do leaflet modification in order to minimize the risk for coronary obstruction. That's a case of severe prosthetic aortic stenosis, a small valve, unfortunately 19 millimeter magna. And we simulated 20 millimeter S3. You can see also this extensive STJ and aortic and annular calcification here. Again, the coronary obstruction risk is very high. You can see basically the ratio is 0.2. You can appreciate here that the prosthetic leaflet plus the calcium in the STJ will obstruct the left coronary, the flow to the left coronary, and the right coronary is probably okay. However, the space looks very tight there as well. And this is the simulation of the basilica, how the anatomy will look like basilica or shortcut now that it's become available in the US as well. And you can see there is ample space here for the left coronary flow. So we have been reviewing this case. We haven't performed this case yet, but it's in the process of being reviewed, and we're planning for it. And you can see here the space created. So again, that's another bicuspid valve type 0. This time, and we're all worried about paravalvular leak in these cases. So this case measured between 23 and 26 millimeter S3. 26 millimeter S3 seemed to be a little too large. The simulation showed we opted for the 23 millimeter S3 plus 2 mLs. There was a gap of 1.5 millimeters, which is right at the border of an acceptable gap. So you see very horizontal aorta as well. So there's a trace, we end up with a trace to mild paravalvular leak. And this is the echo, also showing at 1 o'clock this very, very small paravalvular leak that was actually very predictable after using the software in this position. this software can be applied also for valve-in-valve TAVI. We had here a case of 87-year-old with severe prosthetic AS. The patient had TAVI about 7 years ago with an underexpanded 23mm S3 due to a small annulus. And we simulated different scenarios here, 20mm S3 plus 2 mLs, the 23mm S3, which is obviously too oversized, causing a lot of annular stretch, and it wouldn't work well for this case. We also simulated the evolute valve. However, the frame looked a little compressed and distorted. So given the patient's age and relatively limited functional status, we opted for a 20mm S3 plus 2 mLs, and the result was good, and the patient is doing well.
Staggering.
Very important.
Let's try to expedite because we're a little over the time.
Yes. So so the beauty of this software is you can also, the same simulation, you can simulate the future valve-in-valve and see what it looks like. And the last application of this is also during TMVR, and this is actually a case that I had discussed with Dr. Yakov in the past as well, with severe MR in the setting of mitral ring. The patient had the 32mm simuform semi-rigid ring. You can see the anterior leaflet here in green. You can see also the prior TAVI valve in place. And with the simulation of 29 S3 plus 2 mLs, you can estimate the risk for LVOT obstruction. Here, the NIL VOT area is 225. You can see the anterior leaflet from the aortic view, not obstructing, and the no PVL, no gap. So another application that actually is a project I'm working on now is for the commissural alignment of the balloon expandable valves of the SAPIEN and MyValve in Europe. So, and the goal is to try to predict from the point of entry to the point the valve is deployed in the annulus, how the commissures are going to be aligned. So that's the last slide. Obviously, the more we use this software, the more the predictive power is improved. The most important thing here is to try to validate the use of this software with randomized clinical trials showing that it improves outcomes compared to just conventional CT. And some of the future goals are to perform real-time interprocedural guidance, to be able to estimate post-TAVI gradients, and expand this software in all structural and non-structural heart interventions. I would like to thank you very much, and I'll be happy to take questions.
Great presentation, Nico. Congratulations. Very good cases. It's amazing to use AI. I don't know how accurate it would be, but it looks like all the cases you did, they pretty much, the result is pretty the same like the one you predicted, right? We do something similar at where I work, Tampa General. We have a 3D printing, and we actually try to do exactly the same thing you're doing, but we have the 3D printing and try to put different valves and see how much we obstruct the coronaries. But obviously what you're doing it's much more accurate, it looks like.
Well, it's good.
Thank you.
Maybe less costly. I don't know. What's your experience with the cost of this 3D printing? I'm amazed about how much it really costs sometimes.
It's very, very cheap.
Now it's cheap?
Yes, it's very cheap.
Finally.
They put the software 3D printing, and within 10 minutes you got a silicone copy. And we have some valves that they're used, and we try to put them in, see which one is obstructing, which not. But what you're doing is much more sophisticated.
Well, I have to say that the example that Nico showed, it's a real case. We're going to project tomorrow in the Live in a Box session, great. Tomorrow morning. So this, what Nico's did, with this simulation helped us a lot in a practical way to make a good clinical judgment and then provide the proper therapy. So good, Nikos. This was an amazing presentation. Thank you.
And I really like the bicuspid you did, Nico, because I saw there was not much of a calcium there. I would be very scared to put a valve with such little amount of calcium, but it seems that your valves stayed in pretty good position, right?
Yeah, it was a more fibrotic. It was a more fibrotic pathology, but the valve was, very stable and very good.
Oh, very good, excellent. Thank you so much, and thank all the panelists that for the presence in this session. Who gonna go